Years ago, sex education used to be enough. We had a very unsophisticated population as opposed to with, all the stuff on the internet now. There's continuous education about these things. Some of it correct, some of it incorrect, of course. But that was all that was needed. So a 50-year-old married man with ED was referred to me by his urologist who had scheduled him for penile prosthesis. So he asked me to see him for site clearance prior to placing the implant. This guy was a marathon runner, but injury had sidelined him a decade ago. But he still woke up early every morning and he ran 5 miles. He reported previously active sex life until a year ago, which is why he went to see the urologist. And he seemed very content with his marriage. So in session 1, I asked him, after some of these other questions that we were just talking about, I asked him what he thought the impact on his sex life might be if he cut the running back a little bit. He laughed and he said he would give it some thought. So we scheduled a follow-up session a couple weeks later. He canceled that 6 days before and left a message that he cut back on the running, he's getting more sleep, and they had already had sexual intercourse successfully twice, and both of them were thrilled. Fortunately for me, the urologist still refers to me because, of course, he canceled that surgery. A sex status at follow-up will reveal the initial causes of potential treatment failure, whether current or superficial, right? So you keep going back to getting these details. And deeper issues, again, may require intervention. But you just pivot and adjust the timing of your interventions according to the pushback you receive. Now, using this approach, patients can be weaned from medication, or it can be reduced further, improving the risk-reward ratio. So I see these PDE5 drugs, for instance, as something that can help somebody who's got a severe problem, and then you can gradually get them using less of the medication or wean them completely from the medication. Just like if somebody has a headache, they'll take an aspirin. If you don't have a headache, you typically aren't taking Excedrin every day, or you create other problems. So I see these drugs the same way, and especially with young men, because there's so much, again, on the internet with the distribution through these various companies where you can just go online and essentially get a prescription 15 minutes later after a 10-minute screening phone call from a physician. By the way, do you know, this surprised me, maybe you guys would all realize this, but I'm on the advisory board for Roman, for Ro, which is one of these companies that you see advertising. So I asked the fellow that runs it, the CEO, I said, like, by the way, who are these doctors? And, I'd like to take a look at the protocol they're using. I said, these are retired urologists or psychiatrists. Who are these people? He goes, no, actually, they're women who've recently delivered and they're stay-at-home moms, but they can pick up some extra money by handling these phone calls. So clearly these guys are getting the medication prescribed at a fairly low threshold of focus compared to the kind of in-depth stuff that we're talking about here. So with younger men in particular, what I'll say to them is I'm sure new things are going to be discovered that'll help you when you're like my age. But for now, why don't we see if we can get you functioning and then cut back on the medication, have you build your confidence, have you build your understanding of your own sexuality so that you're able to function with less of the medication and then wean yourself from it so that when you're older and maybe you're on more other kinds of medications that interfere, your health isn't as good, you've got something to fall back on. Because if you continue to rely on this now, this quote unquote crutch, you are going to have a little problem in the future. So this is something I'll discuss very explicitly with the patient. So obviously the frame I'm using is a very open and communicative one with the patient, which is certainly different than how many people might be doing therapy and how it's different from how I might do therapy myself when there's a different kind of presenting problem.